Good morning, good afternoon, good evening, wherever you are, and welcome to a new IFSO webinar. This is a different theme, ethical dilemmas in bariatric surgery, and we're delighted and privileged to have such an esteemed panel. Dr. Khalid Gaudat, who's well known, the famous photos all over from Dr. Gaudat's production. From Egypt, Dr. Renu Rajan from Malaysia. Welcome. We're going to have Dr. Filshauer, who's a little bit delayed, join us later. We're going to have great presenters as well. My friend and colleague, Dr. Mohammed Al-Haddad from HealthPoint, United Arab Emirates, and Dr. Matthew Crow from Cleveland Clinic, Abu Dhabi. All welcome. We're going to have Sylvia Weiner with us a little bit later, joining. She's a little bit delayed as well. Without further ado, we're going to start with Dr. Al-Haddad. Before we start, we're going to launch the first poll. If you faced a case like Dr. Haddad's, a non-compliant patient with no understanding of bariatric surgery, but consenting to lose weight rapidly, please select one of the following options. And I'll go to the panelists. Dr. Gaudat, if you face such a patient, would you offer bariatric surgery?
Well, I would give them extensive counseling and make them understand that there isn't such a thing that as a completely non-compliant patient with no understanding just wants to have surgery. So we'll go through the usual procedure and make them understand, and then we'll take it from there.
Dr. Rajan? Renu?
Oh, yes. I would give the patient the benefit of the doubt, maybe just one consultation. If my junior residents tell me that she's non-compliant with poor insight, I'll give her one consultation again, repeat everything from top to bottom, head to toe. And if I still feel she's got no insight, then I would probably not offer bariatric surgery, because I think the best surgery in the best of hands does not equal to successful outcome if you choose the wrong patient. So choosing the right patient is pivotal in this case.
Great. So we'll close the poll. And as you see, 75% would offer after MDT intervention. So that's a good thing, and they agree with the panelists. So Mohammed, please go ahead.
Good morning, good afternoon, and good evening. Just like what Ahmed says, wherever you are, thank you very much for the opportunity to present. And the case is just, I have no disclosure.
Your voice is a little bit
muffled.
Do you hear me now?
Yes.
Okay. So just a background about bariatric surgery. We all know metabolic and bariatric surgery is kind of a behavioral surgery, and the outcome largely dependent on the patient and the surgery. So sometimes we do the best surgery, but the patient is non-compliant, and then we don't have good results. And the long term, we know on the long term, the maintenance of weight loss really depends on the patient ability and willingness to make changes on the exercise, on the emotional relationship with food. Short term, everybody will lose weight. We know that, as we call it, the honeymoon period. But on the long term, we will need more than this. I know compliance is a subjective assessment. Unfortunately, we don't have a tool that will really tell us how would be the compliance of the patient. Maybe the patient will tell you he will be compliant at the beginning, but after surgery it will be different. There is no objective assessment, as I said. But I think MDT, just like what the panelists said, MDT is one way to assess the compliance of the patient by more than one healthcare provider, and probably would give a little bit more. We did a study which is undergoing right now by my colleague, Dr. Khalid, trying to measure if the compliance before surgery would affect the outcome after surgery using surrogate markers like commitment with the clinic visits and weight loss before the surgery. We don't mandate weight loss before surgery here, but we do ask the patient at least to maintain their weight. And with the logistic regression analysis, we were able to see the prediction is 75% is accurate at 1 year to 2 years. So the case, this is a real case that I've seen, a 45-year-old female, BMI 60. She had no associated obesity-related diseases. She had a history of 2 open ventral hernia repairs, 2001 and 2011. The patient was not complaining about her weight. She was complaining from the hernia, so she went to see a general surgeon, and she had a huge ventral hernia recurrence. But the general surgeon advised her to lose weight or do something about her weight before doing the surgery. Otherwise, the hernia will come back. And he was right on that. So he referred the patient to us. Now, the patient, we have 2 kinds of patients here at that time. She comes with an approval from her insurance to do the surgery within 4 weeks. So she comes to our center with her husband and 21-year-old son to consider metabolic surgery, bariatric surgery. I did explain to her that she will need a multimodal treatment because she's morbidly super obese, and probably will start with the sleeve, and then we'll see what to do about the hernia, and probably she will need another stage of surgery later on. It depends on the outcome. To me, the patient had no clear understanding of bariatric surgery, and she was as if she was brought by just because the general surgeon referred her to me. When I told her about the consequences and the plan and the risk, including her surgery and the lifestyle modification needed, the patient said, no, I can't do this. And the husband and the son agreed with her that she would never be able to do this. Surprisingly, the patient changed her mind while she was in the office after an argument with her son and husband that she can do it, and they kept saying, no, she cannot do it.
So, Mohammed, let me interrupt you. So this is within the first setting, right?
Yes.
The first initial setting.
Yes.
So I'll ask the panelists and get back to you, Mohammed. How many times do you feel the patient is actually adequately counseled? Do you feel that the patients are adequately counseled from the first setting? I'll go to you, Dr. Rajan.
I think in the first setting, they're usually overwhelmed, especially if they're referred by a different physician, like an endocrinologist or an orthopedic surgeon, right? So they go to this orthopedic surgeon because of their knee problems or back problems. And then suddenly the surgeon says, you know, you need to lose weight for the implant to actually hold more than a year. So now they're in a state of shock, like, what is this bariatric surgery? Then they come and see us. So everything can get a little overwhelming in the first setting. So what we usually do is we actually give them another appointment and say, look, you know, this is our clinic number. Why don't you go home, digest all this information, read up a little bit on the points that we've discussed, and then come back again during the second appointment and tell us what you think about it. And if you think this is something you can do, then let's go ahead, you know. So we don't really expect much of an answer straight away from the first go, unless they've come in knowing about bariatric surgery and they want bariatric surgery. When it's referred by a third party, usually they take more than one sitting.
Okay. And Dr. Gaudat, you live in our culture, in our region, and the patients are a little bit close. So how do you see it in your setting, in your practice?
Well, first, about this case we're talking about, I don't think she's non-compliant. She's just ignorant. She's a patient that was brought, has no information. So let's teach her, educate her, inform her, and then take the decision if she's non-compliant or not. Because at this stage, it's unfair to deny her treatment because of that. But the whole thing is the same worldwide. You need proper counseling. You need to discuss all the issues with the lifestyle, compliance, whatsoever. If the patient doesn't like it, he shouldn't go through it. But unless they are well informed, they're going to give us help.
So, Mohammed, the mic is back to you.
Okay, so I totally agree with all the comments. So that's what we told the patient. The argument was in the clinic, patient and adult, and she wants surgery. Family and my assessment that she's not ready for surgery. Now remember that she had this pre-approval, if you call it pre-authorization, to do the surgery within 4 weeks. So we told the patient that it's okay, but we'll do the surgery, but the preparation will take a little bit more than 4 weeks. And you have another insurance, and that other insurance would cover that. There is no problem with that, but it will take maybe a couple of months rather than just a month, maybe 2 or 3 months with the preparation. But this decision is not yes or no from now. It's not only my decision. So we'll go for an MDT. You will see the dietitian, you will see the psychologist, and you will see the obesity specialist. And we will meet and we'll decide whether you are ready to do it within 4 weeks. But it is unlikely, but we will meet, we will do that. Patient didn't like our decision. We did send the patient for dietitian, psychology, obesity specialist, and we have a very good obesity specialist that saw the patient. Now, that first consultation took almost an hour with me, trying to explain the bariatric surgery and what's needed to be done after. Then she saw all of them, and the assessment was from all of us that she is not ready for surgery within 4 weeks. She will need more sessions with everybody before we can do the surgery. Patient was not happy with that, and she decided that she's ready for surgery now. She wants to have surgery. We told her we are sorry, but we can help you, but not now. She took her paper, she took her approval, went to another facility, and had a sleeve gastrectomy. As a stage, there was no complication. We did not see the patient for almost 6 months. After 6 months, patient came back with a weight loss of 10 kilograms. Now she's asking for help. We told her that we can help you now, but you have to go with us now with the lifestyle modification program. You have to see the dietitians a few times. You have to see the psychologist, and we have to study what has been done for you. Patient again didn't like our decision, and she disappeared.
That's a tough situation, but luckily, I think from my standpoint, at least everything was done properly. And Dr. Gaudet, what do you think?
Well, I think that's the plague we have now in bariatric surgery. It's business as usual. So some surgeons have only contraindication for the procedure if the patient doesn't have insurance, and that's unfair. So the patient now is suffering. She didn't have any benefit, and she doesn't want to go through another assessment procedure. So of course you cannot help.
So, you know, when I evaluate my own practice, I look at few things. The way we counsel patients, I look at our internal bias, and could we have helped this patient in a different manner undergo the proper themes? So, Dr. Rajan, if you faced such a patient, and I think the time constraint within 4 weeks as an insurance, maybe that's a motivation for the patient to actually proceed within that window. Would you have done anything different, approach the insurance company, maybe to try to calm the patient down and guide her throughout the process? We can't hear you. Your mic is off.
Can you hear me now?
Yes.
Okay. So unfortunately, in Malaysia, insurance, bariatric surgery is not covered by insurance. But I'll just answer this question in a context where, you know, imaginary wise, it is covered by insurance. So I probably would have written to the insurance company asking for extension of that time frame, perhaps maybe like Muhammad had planned 3 months. Most of the time, I think they would agree because Even in our GI practice, sometimes when insurance companies say, they will cover, they won't cover, they put a certain time frame on certain surgeries, and we write to them and we justify our request, they usually do give in to that request. So I probably would have done that because I think this patient definitely needed more time.
So Matt, you live within the same area, region, same challenges. So how would you go about this patient?
Well, to be honest, I wanted to make sure that Mohammed wasn't going to say the patient came to Cleveland Clinic and we did her revision.
No.
But I think his approach is correct. I think that weight regain and revisional surgery has increased risk, and it's a multidisciplinary consideration as to why someone may not do well. I don't want to propose hurdles because we're treating disease and we want to make sure that patients have access to care. But we also have to understand that there's a huge discrepancy in terms of patients' education, in terms of compliance post-operatively, and accepting what those reasonable outcomes can be, and whether that's in terms of weight loss or in resolution of comorbid disease. Both of those have to be discussed. And depending on what level of information and understanding a patient has when they first present, that can be entirely different from person to person, and the amount of time that any one individual needs varies widely. So there's not a prescriptive amount of time, but patients need to be seen by a multidisciplinary team and understand the risks and benefits and reasonable expectations.
So Muhammad, looking at the process that you did for the patient, counseling the patient, do you think you could have improved the process in order to help this patient, or from your standpoint, it is what it is?
So Ahmed, thank you for the question. The problem was not the insurance, because the other insurance does cover the patient. Her original insurance, she had two kinds of insurance, and she came with this 4 weeks idea that I will need to do it within 4 weeks. And all what we told her, you have another insurance that does cover the surgery. Just wait for us. Just do the process with us. Just let us know that, or feel and believe that you are ready for surgery. You are not ready now, but you might be ready in a month or two. And the patient refused. And it's not a matter of that we are in a public hospital and the appointment will be in 2-3 weeks or 2-3 months. No, we told her, we will work with you. We are willing to work with you until you become ready, or you make us feel that you are ready, and then we will do the surgery. Now remember, this patient had BMI of 60, so probably she will need more than just a surgery. She will need surgery, lifestyle, probably another surgery. She will need a lifelong commitment. She's not coming with a BMI of 35 or 40, and you can say, I will give her this operation and probably she will do well. So the issue was not the insurance. The issue was the patient said, at the end, I want to do it within these 4 weeks, or I will not do it with you.
And how many times in your practice do you usually need to get such a patient ready for surgery?
2 to 3 months.
And do you think you could have done this after you provided an operation or not?
Well, in this patient, I did not, because I thought that the patient was in the clinic, doesn't know anything about bariatric surgery. That was the issue. She needed to know what are the consequences that will happen, the risk versus the benefit. What does she need? I mean, I didn't, because of time, I didn't want to tell you what's the conversation between her and her husband and her son. There was an argument that you can't stop eat this, and she said, no, yes, I can't stop eat this. And then they did go into discussion in the clinic. I told you it was more than 1 hour. 1 hour. But at the end, I believe that she is not ready and she will need a lot of work. And that was the same assessment of our bariatric physician.
So, Dr. Gaudat, if this patient was ready and you counseled her, you think she's ready from a psychological and MDT standpoint, what kind of procedure would you offer this patient?
I am biased, I'm a gastric bypass person, so I have no choice there. And there is also another point for the gastric bypass is that it's an irreversible procedure. When you go to a patient that doesn't understand really what's going on, and maybe I was supposed to do this twice by people that had successful surgery, and they asked to have the same procedure for their elderly mother, but they didn't want her to go through the procedure so that she would not refuse. And she had a hell of a hard time after surgery, and she didn't tolerate, and she was not happy. Offering a reversible option could make sense in these patients. And also this kind of mentality, when you offer her the first stage sleep, they don't come back for the second stage. So even if she's successful or not, but maybe because she had very poor weight loss, she came back for a second surgery. But I would opt for a banded gastric bypass at the beginning, and that's only my personal opinion. It's not scientific.
And Dr. Raza.
Sorry. So I think I agree with Mohammed. I would have not pushed for surgery if I felt that this patient had very poor insight from the word go. If she comes back to me after having undergone surgery somewhere else with poor weight loss, which is what I expect to happen, and which is what rightly happened in this case, I would again repeat everything that Mohammed would have mentioned earlier, which is again counseling, tell her that, look, no surgery is going to be bulletproof for you if we don't identify why you lost only 10 kgs in the first place. Well, in Malaysia, I see this scenario quite often. It's business as usual, like what Khalid said. Everyone's just rushing to do surgery and give in to what the patient wants. And in the patient's mind, it's always my way or the highway. You either do surgery for me or I'm going to go somewhere else, right? I'm going to take my money somewhere else. So if she comes back, I'm going to repeat everything again. I'm sure she's not going to like it and most likely going to have a bypass somewhere else. But I think in our experience, we can say that the patient will still end up coming to your practice the third time saying that, look, I've had a bypass now and I'm still only lost 10 kg. So patient selection, I think from the word go, if you feel like this patient has poor insight and you've done the whole MDT process, keep your doors open, but don't rush in for surgery.
And we're joined now with Dr. Shower. Welcome, Dr. Shower. Hopefully you'll have a safe travel. Joining from the airport.
Yeah, sorry,
so
late, guys.
No worries at all. So we discussed a patient who does not have an understanding of bariatric surgery and needs a lot of counseling, BMI 60 with a ventral hernia that actually came back after going somewhere else, having a sleeve and failing to lose weight. So in your approach, Mohammed tried to offer her MDT intervention, and the patient refused and actually disappeared. So we were discussing the dilemma of how do you get patients ready for surgery in those instances, and how many times do you need in order to counsel the patient and have them ready? In your practice, what do you do, Dr. Shaw?
Yeah, so this is a patient with a BMI of 60. Is that right, her age?
Yes.
45.
45, okay, yeah. Well, I'm sure it's been mentioned, you do the best you can to prepare the patient. And we utilize both nutrition, psychology, medical optimization, prior to surgery, and you get them in the best shape as possible. But sometimes you have to settle for, not the best preparation. This lady's a BMI of 60. She must have a poor quality of life. And so the real question is, even though she may not be optimally prepared, is she more likely benefit from the surgery than not, than live the rest of her life with a BMI of 60 or probably even higher? So you do the best you can to get it prepared, but it's not always perfect prior to surgery.
Great. So with that, let's see what the audience think. Do you agree with Dr. Haddad's decision? Please select one of the following, and we'll have Dr. Matthew Crow presenting later. So I think the entire panel agree with Dr. Haddad's decision, and it's a tough situation for a patient to be in after failing to or not being able to reach the goal. We have our fact checker in the background, Hazem. I forgot to introduce him. Hazem, how did we do?
we did very well. As you know, there isn't much to fact checking in this debate. The only thing I can comment on is Dr. Haddad had spoken about a trial that they're working on currently to look into surrogates that can predict how would patient do after the surgery. And I believe something similar had been published not so long ago, only last year, from the US, where it's a prerequisite by the insurance companies for patients to enroll into a multidisciplinary meeting for a certain amount of time to lose a certain amount of weight before they're approved for surgery. And the outcomes seem to be different to what Mohammed had concluded. Perhaps the sample size is different. So in the US, there wasn't much association between how patients do before the surgery and their outcomes after the surgery. So they found no predictors that can tell us if someone had lost that much weight, had attended all their appointments, will they do better or worse? But other than that, I've got nothing else to comment on.
Thank you, Hazem. That's very helpful.
Ahmad, can I add a short comment, please?
Yes,
Because
please.
we're talking now about compliance, and this is a broad term that is being abused by some bariatric surgeons, because when you have a patient, I heard this from Georgetown 20 years ago, and he described this very elegantly. He said, you guys do the procedure and it works, it's a successful procedure, and if it doesn't work, the patient is not compliant. But then if the patient was compliant, why would he come to you in the first place? So we shouldn't overuse the word non-compliant in patients because they need help. This patient, the example that we took was ignorant, not non-compliant. She didn't know anything about bariatric surgery. But as far as compliance go, we need to improve our procedures to work even with patients that are not very compliant.
I completely agree.
May I just a small point? So
Yes,
would
please.
any of the panelists discuss the option of Saxenda, maybe non-surgical approach? Because I had a similar case, sleeve done, didn't lose much weight, bypass done elsewhere, didn't lose much weight, and then came back third time now, first time seeing me and saying, look, I read about SADI, I read about the other procedures, could that be done? And it turns out the patient had poor insight, she was sugar binging, she didn't meal prep. So very non-compliant patient to post-bariatric dietary restrictions and lifestyle adjustment. Would you consider a non-surgical option in these cases rather than saying no, absolutely no?
From the panelist standpoint, I think all the options are open. What do you think, Dr. Shower?
So the question, would you try a drug?
Saxenda.
Yeah.
Sure.
Liraglutide.
You got nothing to lose, except it's very expensive.
Yeah.
Right?
Yes.
But you got nothing to lose. You can try it, and you'll know within a month or two if there's no response, then it's not going to work.
Right.
But I will say that a BMI 60, a drug, come on.
Yeah.
How much is she going to lose?
Yes.
She's going to lose 5-10 kilos. That's it, right?
No, this 60 had already sleeve done. She had sleeve and then she only lost 10 kilos. So
that's a completely different discussion. Yeah,
I would use it with every revision. Every patient before going to the revision, I would give them the medical trial first.
yeah, I would too.
In case, yeah, for everybody.
I would too.
Great. Let's move on to our second presenter, Dr. Matthew Crow from Cleveland Clinic Abu Dhabi. Please go ahead. Matt will launch a small vote prior. So in a patient undergoing revision, you encounter an unexpected procedure. Dr. Shower, I'll start with you. If you had no clue that the patient had a certain type of procedure, how would you approach that situation?
Okay, let me make sure I get the context right here. You encounter an unexpected procedure. So would I abort and consult the patient? Would I counsel the family? I would proceed with the plan revision if technically, I guess that's feasible.
Yes.
Well, I guess it depends. I mean, if you get in there and you find a patient had an appendix out, well, it's not a big deal. But if they had, a Whipple procedure, then yeah, that would probably alter my thinking a bit. So I think it depends on the magnitude, the complexity of the procedure that you find.
If it's a bariatric procedure, let's say a gastric plication, and you find a gastric bypass, let's say, or a gastric plication and you find the sleeve.
Yeah, I mean, I guess my decision will be determined by, how much additional effort, how much additional risk to the patient. If it's relatively mild, I would probably just proceed with the planned operation. But if it does require a significant amount of extended operating time and increase the risk to some degree, then I would probably wake the patient up, no harm, no foul, and at some other point discuss with the patient, and then reassess the options.
Great. And the audience seem to abort mainly, but they're split on counseling the patient in the family area or proceeding. So let's start and discuss the case, Matt. I don't think I gave you enough due on the example that I gave Dr. Shower. Please.
Yeah, fair enough. So, so I think this is about both disclosure and communication and an ethical component as well. So this is a 40-year-old woman who underwent a band in the 2000s, and she had reflux, not surprisingly, afterwards, and had little weight loss and actually had significant weight regain. She was seen elsewhere, of course, and was converted to gastric bypass in 2013. So prior to her bypass, after her band, but prior to her bypass, her weight was 105 kilograms, BMI of almost 50. She reached a weight nadir of 67 kilograms, BMI 32, and at the time in 2013 had regained to 83 kilograms, BMI of 39.5. So in 2016, she was seen in clinic elsewhere, and she at that time had a BMI of 39.5. Her hyperlipidemia, which previously had been treated, had now returned, and she carried a diagnosis apparently of prediabetes, and she had reflux, which is important. Not the reason why she was seeking evaluation or treatment, but she was on twice daily PPI, and she has a strong family history of metabolic disease, including hypertension, diabetes, and atherosclerotic heart disease. So at the time, I have these images. Her fluoroscopy on your screen left is this, and I'll let that run through a couple of times. And then on screen right is some still images from her upper endoscopy at the time. So what you see first here is the GE junction. And now you see the anastomosis. That's the size of the anastomosis, and that's the jejunal limb. And the report says the pouch was 9 centimeters in size, and the anastomosis was 4 centimeters, the gastrojejunectomy. There was no bile in the pouch at the time. Okay? So the decision made elsewhere was that the patient would undergo an endoscopic gastrojejunectomy reduction. And this was done with a 4 centimeter anastomosis initially, down to 9 millimeters. Now, these are the images prior to that intervention, which is fascinating because when I look at this, one of the first things I see is there's bile in this pouch. But the GJ revision was done in kind of the standard manner, APC to the edge. The overstitch device was used, and you can see down in the bottom right-hand corner here is a pouch reduction of the anastomosis. Okay, 2016. So now she comes to Cleveland Clinic in 2018, was seen by one of my partners for weight regain. Now remember, prior to her gastric bypass, her BMI was 40, now her BMI is 42 after she has this GJ revision. Same diagnosis, hyperlipidemia, prediabetes, and reflux. She was seen by our multidisciplinary team, a dietitian, a psychologist, endocrinologist, and pulmonary for suspected sleep apnea. Now this is what was done here at Cleveland Clinic. So I'll show you this fluoroscopy again. Maybe that's not running through. But this is the upper endoscopy. This is one of the tags, the T tags there. And this is the pouch. Not great endoscopic images, unfortunately. And I'll tell you that fluoroscopy is very similar to the previous fluoroscopy showing one limb going down. So the patient was seen by our MDT, and given the weight regain, the comorbid disease, opted for distalization. Now, there were a couple of maybe red flags that you'd previously seen that you may want to hone in on. But since this is about ethics, the patient was consented for a lysis of adhesions, and the specific verbiage that was used was revision of gastric bypass. So the patient was taken to the operating room laparoscopically, underwent a laparoscopic lysis of adhesions, but again, done by someone else, not me. The anatomy seemed a little strange. The pouch obviously was big. It was 9 centimeters in the upper endoscopy, not that big in the operating room, but long and tubular. And what's interesting is there were 2 limbs coming up to this long pouch. And an intraoperative consult was asked of me to come in and do an endoscopy in the OR. So the patient's laying supine. I noticed that there actually is bile staining of the patient's face. And this is the cricopharyngeus with bile and some esophagitis. Patient had LA grade C esophagitis with bile at the esophagogastric junction. And then with this endoscopic image, you can see that there's clearly 2 limbs coming up to the pouch. You can see one of the T tags from the overstitch, and you can see the laparoscopic light at the end of one of those limbs. So the question is, what would you do finding this? And I'll give you a little bit of information again, as the patient was consented for, and the verbiage is this. It's unfortunately a smart set that we have here: lysis of adhesions and revision of gastric bypass. And the patient's sister is waiting waiting outside.
So, Dr. Gaudat, what do you think? So this is clearly a 1 anastomosis gastric bypass with reflux esophagitis. The unexpected part was that it is 1 anastomosis rather than Roux-Y. Am I correct, Matt?
That's right. A lot of imaging, and it was missed a couple of times.
So what do you think?
Well, we'll do the distalization and revise the gastric bypass.
So do you think it's there's an issue with the consent? Let's go to Dr. Shower. Do you think there's an issue with the current consent and proceeding?
Well, the current consent is pretty vague, or the current plan: lysis of adhesions, revision of gastric bypass. There's only about 1 million different options. Maybe it would be ethically appropriate to narrow it down just to a few hundred options. So Matt, do you have any sense what the patient consented for? What was the operative plan?
Well, let me tell Khalid this too. The patient came for weight regain after a mini gastric bypass, after 1 anastomosis gastric bypass. So a malabsorptive operation. And really the initial reason why she came back was for her BMI 42. Now it's clear she has reflux. And she has twice daily PPI. When I scope her in the operating room, she has LA grade C esophagitis, and she has bile. But that's not why she came in.
So do you think yes, please go ahead.
Question, yeah. So Matt, was she prepared, was she counseled about a malabsorption operation, a distal bypass? Was she prepared for that? Was it deemed that she was a good candidate for a distal bypass?
She was. That was the plan.
That was the plan?
Yes. For distalization, probably disconnecting the afferent limb and a distal jejunojejunectomy.
So Matt, do you think this is an issue with preparation or an issue with consent and counseling the patient?
Well, I like this case because I like the panel and everybody who's talking here, because I know Dr. Shower and I have with being in UAE for 3 years, the vast majority of patients who come here with a gastric bypass actually have a 1 anastomosis gastric bypass. So I think one of the points I'd like to make is that there has to be an understanding from a surgeon standpoint that we know that all Roux-Y gastric bypasses aren't constructed the same. But now when we talk about gastric bypass, that's a plethora of other options too. So I think that's an important point to make too. But yeah, but in revising this patient from a distalization, changing the limb lengths of what was presumed to be a Roux-en-Y gastric bypass to a distal Roux-en-Y gastric bypass may be entirely different than converting from a 1 anastomosis gastric bypass to even a distal Roux-en-Y gastric bypass, though admittedly the verbiage of this consent is vague enough that I think it probably encompasses that. But does the patient really understand what the expectations are going to be after this operation?
Yeah,
So,
well, Matt, you started with the patient thinking she had a Roux-en-Y gastric bypass, and you think she had a Roux-en-Y gastric bypass, and you wanted to distalize. And now you find the side effect of the mini gastric bypass. So converting it into a small pouch Roux-en-Y gastric bypass and making it distal sounds with the plan. So it's just, I think it goes with what you consent. Even the consent is perfect, vague.
So, Dr. Rajan, you live in this area and you face 1 anastomosis gastric bypass as well. What would you have done in that situation?
Yeah, so I would have done what Khalid just suggested, which is a small pouch and then a distal bypass. That's what I would have done, because the consent is quite vague. If he had said RYGB, then maybe I would have to, you know, go outside, speak to the family and stuff. But if it's just gastric bypass, I think it leaves a window of opportunity to just do a small pouch and a distal bypass.
And Dr. Shower, now we know the results of distalization as in Roux-en-Y gastric bypass, proximal to distal. We have some idea. Do we have any idea about distalizing a 1 anastomosis and what the results are?
Well, I mean, I think it does increase the complexity of the operation a little bit, especially if you're going to reduce the pouch size to some degree. So, I mean, I think this would be a tough call. I mean, I don't like the consent, frankly. I think it's a bit vague. In this case, you know, unless there are other extenuating circumstances, I think I would err on the caution side. Wake the patient up, explain to her what you find. I would tell her that she needs to have this 1 anastomosis bypass revised because it is the cause of this severe reflux, and then suggest that you know, as a surgeon could also do the distalization as well. So I think I would wake her up and discuss it with her. But this would be a close call. I mean, as it is, a consent does encompass that to some degree. But I think I would just err on waking her up and going ahead and discussing the options with her.
So Matt, what did you do?
Well, should we take a vote? Or we're going to go through this whole thing? All right, I'll tell you what we did. You want to vote, or what do you want to do? It's up to you.
We'll vote later.
Okay, all right. So we aborted the procedure.
Good
we
man.
did not talk to the family. Thought you'd like that. The patient woke up and we discussed with her getting a new consent, and in particular with a more focused discussion about her symptoms, this reflux, which wasn't glossed over, but maybe wasn't vetted as well as it should have been. She really did have significant reflux too, which was corresponded to her LA grade C esophagitis. So 2 or 3 days later, she underwent conversion to a long limb Roux-en-Y gastric bypass with a pouch revision from a 1 anastomosis gastric bypass. And Bill, what you're hinting at is that often distalization is just a jejunostomy revision, but you know, we typically don't affect the pouch and the GJ. In this case, there were 3 new anastomoses with a redo of the pouch as well. Now, interestingly, she had minimal weight loss. I mean, maybe not surprisingly. You know, her BMI was 42/4. It was 40.5 after about 12 months. But she's very satisfied. Her reflux and she had some bloating, which really wasn't vetted out, had been resolved. And even though she hasn't lost much weight, she is happy with her results. And I just want to give a citation for our experience here at Cleveland Clinic Abu Dhabi with conversion of 1 anastomosis gastric bypass to Roux-en-Y for complications.
So let's launch the poll, Manuela, if we can, and we'll get to you, Dr. Shower, once we do. So do you agree with Dr. Crow's decision? And meanwhile, please, audience, answer. Dr. Shower.
Yeah, Matt, can you share with us what limb lengths did you use for the distalization?
150 RU limb, 150 BP limb.
So, Dr. Shower, would you
Okay,
have
that's a
gone?
modest. That's pretty modest. Yeah.
I would say, Bill, it's not a distalization. It's just a long limb bypass.
And
Okay. Yeah,
what,
I'm not surprised. There's no weight loss. Yeah.
and what was the original biliopancreatic limb, Matt?
From the one anastomosis gastric bypass?
Yes.
Well, the common channel was 200 centimeters.
Okay. So the common channel was 200, and the biliopancreatic, did you measure it? Or?
The biliopancreatic limb was 200.
And the common channel, did you measure it?
It was measured. To be fair, I was only the endoscopist in this case.
Okay. So we'll leave that to another discussion, another scientific discussion on revisions. But Dr. Gaudat, do you agree with what was done?
Well, I think we had only one option to offer to the patient. So my idea of going with the procedure without further consenting, because we have only one option, that could have been okay. But my take on revisions is that with every revision, I have to measure the whole total bowel length. I'm now doing revisions of 2 or 3 previous bariatric procedures, and I could discover that the bowel length is 11 meters and 9 meters. So whatever we do proximal is not going to work. So I would recommend in every revision case, we have to measure the whole bowel length.
Great. Dr. Rajan?
Same BP limb of 150 and 150 on the other side. So same, a modest distalization.
Yes. Okay. Dr. Shower, would you have done anything different?
Well, I'm not surprised that the patient didn't lose much weight, but I'm also cognizant of the fact that I know folks in the Middle East have different dietary habits, so they may not be as amenable to some of these distal bypasses because they can get in trouble with severe protein calorie malnutrition. So I think it's really important up front, if you're going to do a distal bypass, that the patient is very prepared. I think they require a lot more counseling regarding not only diet, but also monitoring post-op. So I would leave that judgment call, to the surgeon regarding his or her determination as to the patient's preparedness for a distal bypass. But in this case, there wasn't much done in terms of a distalization. So I'm not surprised there wasn't much weight loss, but the patient's better off though, because the GERD's gone.
Great. So Matt, if you were the surgeon, would you have done anything different?
No, I think it's reasonable. I think that the one important takeaway from this for me is a fluoroscopy and an endoscopy, especially if it hasn't been done by a bariatric surgeon, may not be enough prior to a revision. So either do the study yourself, make sure it's done properly, or maybe get a CAT scan too. That'll delineate the anatomy prior to revision, so you know exactly what you're going into.
Great, I agree. And going into both limbs in the preoperative endoscopy can help as well, other
Absolutely.
than fluoroscopy.
And a thorough investigation. Sometimes what looks like a candy cane or a long candy cane may be an afferent or efferent limb. So we have to be, very careful that there are many different types of gastric bypass.
Definitely agree with it. So Dr. Sylvia Weiner is with us after a long day in the OR. Thank you for joining. And while you're launching the presentation, we'll launch the poll. Before we launch the poll, Hazem, how did we do?
As always, guys, you did very well. I mean, there isn't much to talk about. You've talked about the distalization, and the only paper I could quote is the one by Kelvin Higa, where he went on to talk about the various types of distalizations. And we all know from experience that with revisional surgery and even with a distalization, the outcome is never going to be 100% satisfactory as with primary surgery, because there are factors related to the patient. So while others have raised criticism or comments about the length of the limbs, this probably goes with the natural physiology of the patient. Some of them, regardless of how short or long the limbs are, the weight loss is never going to be the change. In this case, the patient had gained a lot by improving her reflux and quality of life, but for the weight loss, considering, and in this part of the world, because I share a similar experience to Matt, is that these patients would have multiple revisional surgeries, but they still don't lose weight. And it's probably all to do with the education and the lifestyle and the dietary habits. So other than that, I've got nothing to add. Thank you.
Thank you. Thank you, Hasan. So to the audience, patient with laparoscopic adjustable gastric banding, BMI 30, smoker with no weight loss and a band slippage years later, what would you offer to this patient? So this is a complex patient who had a band at BMI of 30. Dr. Rajan, what would you do to this patient, looking at the options?
What would you offer? Band removal. I would remove the band and then consider converting this to a different surgery, maybe in a later setting. That would be my plan.
Dr. Gaudat?
No weight loss, smoker, band removal, and counsel from the beginning, from scratch, if she wants surgery later.
Great. Dr. Shower?
What was the patient's initial BMI?
So the initial BMI was 30 and no weight loss.
Okay, so it's still 30. Okay, and is the patient symptomatic from this band slippage?
Yes.
Okay, yeah, I think I would offer just band removal. Yeah, band removal.
Okay, and let's see what the audience shows. And the audience is actually sharing your opinion with band removal. 28% would do sleeve gastrectomy at the same time. So let's go to Sylvia's presentation and see the details of that patient.
Okay, hello everyone. I'm sorry for being late, but I was struggling with the OEGB and a BMI of 85, so I had to do it myself. I'm sorry about that. So just need to see my presentation actually, so I can do it. Okay, first of all, we had this patient who was at age of 56, and she had placed a gastric banding not in our country, and she was also self-paying due to the fact that she was very much suffering from chronic back pain. She had 2 disc prolapses, and she was in need of chronic high pain medication. So that was her motivation to do the surgery in 2016. She was smoking at that time, and she was having initially no dietitian consulting when she was doing the surgery as a self-payer. And we had another problem that she was not a German native speaker. So also when we saw her first time, we had a little bit problems in communicating with the patient. And then we found a German Persian dietitian, so we could a little bit easier the language flow. And what we realized that obviously she's like the most patient could not eat properly. She was drinking a lot of fluids, also like sweet fluids, and her weight was 90 kilograms with a height of 175. She had no diabetes, no arterial hypertension, no reflux, but finally she could not eat. So she was vomiting as soon as she had solid food. So at the very beginning, we were very clear that probably we have to remove it. And we took her on the ward in order to do the diagnostics. So in the diagnostics, we did see that the band was almost at the level of the hiatus. We didn't see too much in the upper endoscopy, where we're sure that we had no migration of the band. But as you can maybe see in the X-ray, that the band is exactly at the hiatus of the patient. So we were talking with the patient twice, and we told her that we have to remove the band in order to resolve the problem with the eating behavior, so that she can eat again. But she was very much begging for another procedure in order to get some more weight loss in order to clear out her back problems. And we had several talkings with her and about 6 months time of consultation with our dietitianist. And but we quickly removed the band. And what we always do is not to do a second procedure at the same time. So this is in our clinic, it's always clear we remove the band, and whatever we do or as a next step, we always wait for at least 6 weeks in order also to see how the patient's problems are dissolving, how the patient's behavior is to our outpatients clinic, if they come back, if they follow the eating behavior. So that was what she did. And we were thinking, okay, just band removal, maybe band replacement. She was very much asking us for a band replacement because in the end, she knew that at least she did not gain weight, but she was expecting further weight loss, even if it's not too high with a BMI of 30 or at least 29. And we were asking ourselves if we just wait for weight regain and proceed bariatric surgery maybe in 2 years when she's maybe at BMI of 40. If we do a sleeve, but actually I'm very afraid of the risk of insufficiency, especially at this very critical low BMI indication. I think the reason why gastric bypass is a problem because she is a smoker, and the OHGB has a side effect, so I was fearing to have too much weight loss.
Okay, so let me interrupt you, Sylvia, and ask the panelists. I know Dr. Shower has to leave shortly. So Dr. Shower, first, what do you think about this patient and what your approach would be?
Okay, so the band is out and her BMI is 30.
Yes.
No, the band is still there.
Still there.
Is still there, and the patient is asking for another procedure, despite her initial BMI being 30, and now at 29, a smoker who cannot eat.
And comorbidities, the only thing I heard about comorbidities was back pain. Did I miss anything?
Exactly.
No.
Only
No
back pain.
diabetes, no sleep apnea, no hypertension, dyslipidemia.
No, back pain and on opioids, which is a big issue in the United States now, and opioid-dependent patients and having to undergo an operation revision. What would your approach be? What would you counsel the patient? What would you offer the patient?
I don't think there's really much for her to benefit by another weight loss procedure to BMI of 30. I mean, dropping her BMI from 29 to 25, is that going to reduce her opioid requirement? I don't know. I don't think so. So I don't think I'd offer anything else at a BMI 29, 30. I would just take her band out. That's how I offer her at this point.
And Dr. Gaudet, we know that once you remove a band, patients tend to regain weight. I know there's only one publication that follows band removals long term, and Hazem can correct me if I'm wrong. But in those patients, the band patients tend to regain whatever weight they had. They usually do not exceed their baseline. What's your experience in that situation?
Well, it's, if she doesn't qualify for the weight loss surgery in terms of BMI now, even though she's a redo, but my only concern here is that the preference of the one anastomosis gastric bypass versus Roux-en-Y because of smoking, because one anastomosis gastric bypass, maybe you've seen the study from Sultan Tumyat, they get very aggressive anastomotic ulcers, and these are very complicated, and when they perforate, they are much more morbid than the Roux-en-Y. So I don't see the whole point of Sylvia choosing one anastomosis versus Roux-en-Y based on the smoking history. So either one anastomosis Roux-en-Y, she had to quit smoking. And in that scenario, I would just remove the band. And if she is ready for the multidisciplinary approach, then I would go through another procedure.
Dr. Rajan?
Okay, so I would discuss this case. I think I missed the point where the patient is on a high dosage opioid derivative pain medication. So would not jump into surgery for this case, but I would definitely bring this patient up for MDT discussion. And if the orthopedic surgeon says that, look, the pain from the disc prolapse will reduce with some weight loss, then I will counsel the patient for two options. One would be a non-surgical option, which would be Saxenda, and then the sleeve gastrectomy over the gastric bypass because of the risk of marginal ulcer in this case. But having said that, if there is any concerns about her not being able to wean off from that opioid medication, or if there's some concerns about addiction to that opioid-based medication, then I would probably lean more towards the non-surgical approach, which is liraglutide.
So in your practice, Sylvia, would you offer bypass for smokers?
Yes, I do. And I know that's always a very hard discussion. Maybe it's due to the fact that I'm a smoker myself, so I'm a bit more relaxed regarding this issue. But when I see patients with smoking about 5 to 8 cigarettes per day, I have never seen in the last 15 years really a chronic ulcer. I think if we see chronic ulcers in patients, if they're smoking, in the most cases, if we did a kind of redo surgery or replacement of anastomosis or anything else, we did see that they have a bigger pouch than the others, so no proper primary operation, or that they had kind of like gastrogastric fistula or anything like this, so like acid-induced ulceration or ulceration due to the fact of taking non-steroid antiphlogistics. I know that's not the literature, but I think we are maybe putting misinterpretation to the extent of the impact of smoking. Of course, if there's more than 10 cigarettes per day, I will definitely do no bypass procedure. But if we're talking about small amounts, I just do it, and it works well.
So,
Sylvia, just a question. So if someone says they smoke 4 cigarettes only a day, would you take that like, yeah, okay, I believe you?
Yeah, we have a very confidential thing with our patients because we see them at last 4 times just previous the surgery, and we let them take protocols. And if I have the feeling that they are not speaking openly with us, then of course we have to consider that. But in the end, I'm always relying on what patients are telling me, even also in the aftercare. I mean, if they don't tell me that they are not taking the vitamins, if they're lying to us, there's nothing we can do. They are adult patients, and I have my patients always sign the IFSO agreement on patients' responsibilities. So I explain to them that's very important that they are honest. And in the end, we have to believe the patients if they have antihypertensive therapy or not, or if they're taking maybe psychological medications, and they're not telling us. So we're a little bit, of course, relying on the patients. Yes, I do.
I think we tend to see a little bit higher marginal ulcer rates in Southeast Asia and East Asia. So it can go up as high as 16 to 20% in Malaysia and in the East Asian countries. So we still don't know what the reason is. Some think that it's because of higher prevalence of this marginal ulcer in rice-based countries. I'm still not sure what the cause is, but if someone has H. pylori or smoking, then that's just going to add to that increased risk of marginal ulcer in our population. So that's why we would err towards, if a surgical intervention was needed for this case, it would be a sleeve rather than a bypass. Not just because of the smoking, but because of our experience seeing a higher prevalence of marginal ulcers in gastric bypass patients.
Of course, I do discuss this issue with the patients, and it's more the tendency, of course, to offer the sleeve to the patients. But when you see patients who had, for example, a relative dying at the sleeve procedure, for example, and they are completely denying a possible sleeve, and they only want to have a bypass, and I explain to them that they must not smoke that more than 5 to 6 cigarettes per day. And if they really have understood it and I put it in informed consent, I do it.
So, Sylvia, did you find this patient vomiting a lot? The X-ray and the endoscopy doesn't show a big slide of the like the band is in a perfect position and endoscopy is okay, and so
exactly in the hiatus.
Okay.
And
so I mean, does this, if you empty the balloon and try first conservative measure, did that improve her eating at all, or it didn't work?
It was never blocked at all.
Oh,
But of course, we did try to empty it, but it was empty. So there was no solution for that.
So let me take the other side. This is not only a case of, I think it's a band intolerance rather than a slippage, but if you have asked the patient to quit smoking and they successfully quit smoking, how many patients actually go back to smoking after you do a gastric bypass? Let's say, Dr. Gaudat, you live in the Middle East, and we have a lot of smokers in the region. How's your experience?
well, I tell them very hardly that you have to stop before surgery, but they never stop. And even if they stop 6 months later, they come back to smoking.
Yeah.
And
My experience.
yeah, and you know, majority of smokers, they tend to, in my practice at least, they tend to re-smoke again. And you know, all the ulcers that I've had are in patients who quit smoking and came back to smoking after gastric bypass. So hopefully we'll see what you did, Sylvia. So
And that
what did
speaks a lot about the micropouch here. You know, when you have a micropouch, you have less acid, so less ulcer. Okay.
I'll share with you a complication of one of your patients, but that's for
Okay.
later.
And next webinar.
Sylvia, so what did you do?
So in the end, I mean, we had a lot of discussion with her, and originally she was scheduled for OR just in before Christmas time. And I said, I'm not going to do it in the week in before Christmas. I don't want to stand here during the Christmas days and discussing with the patients and having complications. I had a bad feeling. So I was postponing her. That was my first decision because it was very unclear. We had a lot of discussions going on. But in the end, we decided to at least remove the band. That what we did it initially. So when she came, she had a problem. We had a diagnostic. We removed the band and we scheduled any kind of surgery just previous to Christmas originally, and then I postponed that. What we always do is we always get informed consent from all our patients for all kind of surgeries, so including sleeve, OEGB, Roux-en-Y, BPD. So we ask the patients to leave the decision, the final decision, on our intraoperative findings, if there are no hard contraindication for the one or the other. And of course, also in these patients, we, when we're explaining the gastric bypass, we were explaining very much on the necessity of to stop smoking, the risk of ulcers, and we were very much explaining about the risk of sleeve insufficiency. And what happened is that finally the patient stopped smoking in before Christmas time, and she came back after. In the new year, we were re-evaluating everything, and she was already gaining 2 or 3 kilograms after the band removal. So let's decided to do, after the band removal, 6 weeks later, we did a Roux-en-Y gastric bypass. And of course, with this patient, we had, of course, a small complication. I had a bleeding of a staple line, which required laparoscopy. We had a very strong hard scar tissue at the old band place. So I was very happy with my decision not to do a sleeve, to be honest. And we, of course, did not decide for an OEGB due to all the side effects. So I finally did a gastric bypass. And she just came back just right now, yesterday. She lost 7 kilograms already, and her pain medication is completely reduced, at like 50%. She's still not smoking. She's very, very happy. So in the end, maybe I'm still a little bit afraid of maybe getting a complication due to the ulceration. But as long as she stops smoking, which I really like, I think it was the right decision, I hope.
So let's launch the last poll and see if the audience agree with what Dr. Weiner did. And I'll ask the panelists as well. So do you, Dr. Gaudat, do you agree with Dr. Weiner's decision?
Yeah, a staged procedure, stopping smoking first, perfect.
Dr. Rajan?
Staged procedures, stop smoking, but maybe not the gastric bypass.
So, Sylvia, what was the patient's BMI before the gastric bypass? Did it change? What did how much weight did the patient gain?
It was 30. So when she came first time to us with a band, it was 29. And in the time slot between the band removal and the gastric bypass, which was 6 weeks, I think 6.5 weeks, she already gained 2 kilograms. So she went up to a BMI of 30.
So let's see what the audience has to say, and the majority agree, but still 38% said they do not agree. And the question is, do you think that we should offer bariatric surgery at such a low BMI, Dr. Gaudat?
There's a saying, and some people say with revision surgery, you don't stick to the BMI. So if a patient has a BMI of 25 and is vomiting from sleeve gastrectomy, you would make them room-wise so that they don't stop vomiting. So, but this patient started at 30 and stayed at 30, questionable.
Dr. Rajan.
Again, if she's opioid dependent, shows addiction towards opioid, non-surgical weight loss option. But if she is not an addict to the opioid medication, then yes, an MBT discussion. Of course, the orthopedics input is very important here. So if they say she will benefit from the surgery, then yeah, we'll go ahead.
Matt?
I would be cautious that low of BMI to do another bariatric procedure. I would go with band removal alone.
Definitely. So I think, Sylvia, any final notes on your happy patient?
In the end, I love to not see too many patients in this discussion. I think it's clear if they have an initial BMI of like 45 and they have a band and they lose weight and then they gain again, I think then it's clear that we are not sticking with our revision to the BMI, but we have to stick on the chronic inflammatory disease, which obviously the patients have. In this case, I had a little bit heartburn some days after, because 30, maybe the next time I will not do it. But it's always a hard discussion because the patients are very much begging you for the need. And finally, of course, I'm happy that she could reduce her pain medication. So maybe in this case, it was a good decision. Maybe the next case, it won't. So not a general recommendation to people throughout the world.
Yes,
definitely agree. Not a general recommendation, case to case decision for sure. Yeah.
Adam, how did we do?
We did well. So talking about revision after band, as you said, the paper you quoted, the majority of these patients will regain weight and will end up needing to have surgery in the future. As we all know, band surgery was done at a time when there wasn't much post-op follow-up, not much post-op counseling, and it was sold as a quick fix sort of thing. So a lot of these patients ran into problems, complications. The bands were removed and they'll regain weight. With regard to how to approach revision at the time of a gastric band, both staged and one-stop surgeries are feasible. However, the complication rates are obviously less and the outcomes are a bit better when we do it in a phased manner. And with regard to this patient, I mean, just talking as a fact checker here, I'm not giving any personal opinions. She does not qualify for any bariatric surgery by any international guidelines. I mean, in a Western population, the only time you'd offer bariatric surgery to someone with a BMI of 30 to 35 is if they've got uncontrolled type 2 diabetes. In the East, people from the East, we can drop it down to 27. I'm glad someone talked about medical treatment, because you probably would have similar outcomes from liraglutide or some other medications in achieving a similar weight loss compared to surgery. This patient with a low BMI, she's not going to lose that much weight compared to someone with a higher BMI. It's all relative speaking, and you can achieve comparable weight loss with medical treatment, whether in medications or tablets. So that would be my take on this. Thank you.
Thank you, Hazem. So from the audience, we have a comment from Michelle Vakari on the science and the approach to a patient counseling. It's a long comment. Thank you for sharing it with us. But a question to actually Matt from Harsh Chef. Ethics are on one side and cost on another. In a setting where bariatric surgery isn't covered by insurance, would you actually abort and double the cost of OR anesthesia?
I, having come from the American system recently, I still understand, and it's true in the UAE too, that cost is part of all of our practices, and that's a consideration. You still have to do what's right for the patient. And in our case, we were talking about distalization, which is a revision of a jejunojejunostomy with little morbidity and reasonable expectations. But redoing a gastrojejunostomy, 3 anastomoses from an OAGB to a Roux-en-Y imparts significant morbidity, lifestyle change, and expectation. So even cost consideration, I would have done the same thing.
Great. We got the same comment from Dr. Ramos, actually, from Brazil, and making sure he suggests a wider, well-informed consent in the future.
I would agree with that. I'll pass it on to my partner.
Great. Thank you all for joining. Please, whoever, next month, we're going to have our first MDT meeting with Integrated Health Medical. Join us. Thank you, panelists, Dr. Reno Rajan, Dr. Khalid Gaudat, Dr. Phil Shower, for joining us in the airport despite his difficulties in travels. Thank you, Matt. Thank you, Muhammad. Thank you, Sylvia, for joining us and making this a success. And looking forward to our next ventures. Thank you all.
Thank you. Bye-bye.
Thank you. Bye.